It's really a pleasure to welcome you on this cold, rainy evening to come and join our panel on Ebola. You know, we've got a wonderful and very talented panel that I think will give a very good perspective, balanced perspective on what really is a horrific disease that has now claimed, or what we know so far has claimed, approximately 6,000 lives in West Africa. A few days ago they said it was 7,000, so the good news is that they've reduced that number to 6,000. There were some mistakes in the counting in Liberia, but there will be more deaths. It's inevitable. And up until recently, we in the US have largely ignored this, to our shame, and I think, to our ultimate cost. And if there's one key lesson that I certainly take home from the Ebola epidemic in Africa, is that if we ignore epidemics in other parts of the world, the amount of suffering, pain, economic costs that they cause, then eventually it will come back to us, and we will bear a large percentage, a large burden of that cost. Now, I'm going to be facilitating the panel. I nearly said this morning, that can't be right, this evening. So let me just very briefly tell you who I am, then I'm going to move on and introduce each of the panel members and ask our main speaker to really talk about the details of Ebola virus disease, as it's now called. My name is Tim Ford. I'm privileged to serve as the Dean of the School of Health Professions here at Shenandoah University. My background is actually in public health, and I served for many years at Harvard University, the Harvard School of Public Health, as a faculty member, where I was also part of a working group on new and resurgent diseases back in the early 90s, a group that was specifically put together to start asking questions about why we were seeing what were apparently new diseases emerging throughout the world. And Ebola, as we call it, hemorrhagic fever back then, was certainly one of those key diseases first discovered or identified in 1976. And it was one that we really anticipated we would see, the kind of outbreak, epidemic that we now see in West Africa. We expected to see it a lot sooner. And we published a number of articles to the effect that we really had to show an incredible level of vigilance, and we needed to put in place global surveillance systems that could really be proactive in picking up these kinds of threats. Now, we've been neither proactive or vigilant, frankly, in the US, so I think we've been extraordinarily lucky that it has taken this long for a disease of this magnitude to threaten this country as a pandemic. It's sort of interesting to think about the fact that we've come through the 2000s with major scares from SARS, from bird flu, from avian flu, which of course then turned into a pandemic in 2009, and we had a whole bunch of pandemic flu preparations, and yet we still didn't get the 2009 epidemic quite right. There were approximately 12,000 deaths in the US from that pandemic. So even flu, which comes here annually, which we're well prepared for, we were not prepared in this particular case. Just to put it in perspective, though, before I introduce the panel members, when you think about it, the Center for Disease Control estimate that there are between 3,000 and 49,000 deaths from the annual flu. We've had 2 deaths from Ebola. So I think that's worth thinking about. And where the US and other international agencies, last week I was in the UK and was hearing about how David Cameron, the Prime Minister there, had invested the Department for International Development there for their lack of response. And that's been going on throughout Europe. It's not just the US that have responded very, very poorly to this pandemic. While they have been extraordinarily and shamefully reactive, I think that Shenandoah University and indeed the health districts have actually been very proactive. And certainly I can speak to Shenandoah University and Ron Stickley's work to really put in place what I see as a very effective infectious disease guidelines, policies and procedures. But of course with Ebola, we're dealing with something a little bit different, something that presents some very real challenges. And so tonight's panel is really to tell you a little bit more about the disease. You know, one of the biggest challenges we have are the misconceptions. The misconceptions created by media coverage and by poor quality science. Both are equally responsible for what we've seen in this country. And at Shenandoah and the Health District, I think they've really put in place some very good, very strong policies and procedures should this epidemic continue, or this pandemic continue to threaten the United States. But my message is we really need to address the pandemic in West Africa, because that's where the magnitude of suffering is occurring. I want to introduce the panel members, and I'm going to start the panel discussions with our first panel member, and you'll excuse me if I cheat here, since I haven't, and I'm not only going to have to cheat, I'm going to have to use my glasses, but Dr. Charles Devine is going to talk about the disease, its transmission, and the local response. And he's an emergency medicine trained physician who serves as the health director of the Lord Fairfax Health District, which is part of the Virginia Department of Health. The Health District serves the counties of Frederick, Shenandoah, Clark, Warren, and Page, as well as the city of Winchester. In this capacity, he leads the country's health departments in their efforts to assure the health and safety of the region's citizens. He also serves as interim health director for the Thomas Jefferson Health District, which serves the counties of Albemarle, Fluvanna. Forgive me if I'm pronouncing these completely incorrectly. He said to introduce him as just "Hey you." Fluvanna, Greene, Louisa, and Nelson, and the city of Charlottesville. I'll then ask Mr. Stickley, Mr. Ron Stickley, to speak directly to some of the policies and procedures that he's put in place to protect our students, staff, and faculty at SU. Mr. Stickley has served as Shenandoah University's Director of Health Services for more than 7 years. He's responsible for the oversight of the university's Wilkins Wellness Center and is incident commander for any communicable or infectious disease outbreak on any Shenandoah University campus. He has 30 years of medical and pre-hospital experience and is a graduate of Eastern Mennonite and Shenandoah University. Now, SU is all about providing our students with the best education we can deliver. So I'm delighted that we have two people from SU's Eleanor Wade Custer School of Nursing. You know, all health caregivers are at risk, but I think we've seen over the last several months that nurses really are on the front line. So to have two faculty members from that school is really important to tell the story. Dr. Catherine Gansky is the dean, so more than just a faculty member, of course. The dean of the school, and her work is focused on bioethics, family caregiving, and moral reasoning in nurses. This year, she was named Commissioner of Education for the Virginia Nurses Association. She's published on moral reasoning, moral distress, and ethical implications in caregiving, including participation in the revision of the American Nursing Association Code of Ethics. Ethics and human rights are, of course, all areas of great concern in how we humanely treat Ebola patients and at the same time protect those caregivers. Ms. Gilda Gilbert is an assistant professor of nursing in the school and serves as coordinator of the Nursing Skills Simulation Lab, something you should all tour if you get a chance, by the way. For nearly 30 years, she served in the perioperative nursing practice in small, medium, and large non-profit hospital settings, as well as a private plastic surgery practice. She served in various roles at both Winchester Medical Center and Page Memorial Hospital as a long-time nurse educator through various organizations. I would also have a very special guest here tonight that I'm going to allow Dr. Devine to actually introduce, and we are extremely lucky that she has come and joined us here. So now I will actually turn this over to Dr. Devine to really tell us about the details behind Ebola. Charlie.
Are we set? The special guest tonight is Maggie Burke, who is one of the travelers to return from West Africa. who has gone through the airport special screening, who has gone through the 21-day monitoring that I'll be talking about, and can actually talk to us about what it's like to go through that from the inside out, instead of just listening to me stand up here pontificating about it. Ebola virus disease is the current favored name for what used to be called Ebola hemorrhagic fever. We've dropped the hemorrhagic fever part from the name because the viral disease, typically hemorrhage is seen in a relatively low number of patients and only has a fairly terminal event. So calling it Ebola viral disease is probably actually a better name for it. It's caused by an infection with the Ebola virus, which is in the, I always do this wrong, Filoviridae, I hope that's close, family. And it is a thread-like organism that can assume many different shapes. And so while the slide up there is a flight of fancy, it can be seen in sixes or U's or a number of different shapes. Now, I imagine if we had enough of them, we might could find the works of Shakespeare, though I'm not sure about that. As we said, let's see if I can do this. I'm Charlie Devine, and I'm going to talk about the Ebola virus outbreak, and my job's already been outlined, so we'll just go away from that. Ebola is a severe, often deadly disease that affects humans and is really devastating for certain animals such as gorillas and chimpanzees. It's called Ebola viral disease. It was discovered in 1976 near the Ebola River, actually 60 miles from the Ebola River, but the discoverer chose the name Ebola because he did not want the village he found it in associated in a bad way with a severe viral illness. The natural reservoir really is unknown, but it probably is bats. Bats are an amazing species. They've been around for thousands and thousands and tens of thousands of years, and their immune system somehow tolerates many viruses and lets the viruses survive in their system, and they don't become ill from those viral infections. And rabies is a good example of that. Bats, transmit rabies, and yet bats don't show symptoms from rabies. In the U.S., we've had Ebola disease diagnosed in 4 people. One, the index patient, traveled from Liberia to the U.S. His illness was recognized fairly late. It took 2 visits to the ER, as you all know. Case 2 and case 3 were both healthcare workers who had been providing care for this patient. And the 4th case was a healthcare worker back from West Africa who became ill and was hospitalized in New York. With the exception of the index patient, all of these folks have survived the illness, recovered, and gone home. There have been about 25 outbreaks since the initial recognition of Ebola back in 1976, with some 2,300 total cases before this outbreak and some 1,500 deaths, again, before this outbreak. The current outbreak involves the countries of Guinea, Sierra Leone, Liberia, and these 3 countries have widespread ongoing transmission of Ebola viral disease. Mali, I'm not sure if I'm pronouncing that right. Mali, thank you, was added to the list recently, November 17th, because of cases there with limited local transmission. The signs and symptoms. Fever and headache are typically seen early in the course of illness. Muscle pain, weariness, and weakness also present early. Then the next thing that is typically seen is vomiting and diarrhea, which occurs 3, 4, maybe 5 days into the symptomatic phase of illness. That's associated with a bellyache. Sometimes the bellyache can be severe. There are folks in Africa who were operated on, the surgeon thinking that it was an acute abdomen appendicitis or something that required surgery, only to find out later that it was Ebola. Bleeding is possible, but that's usually a terminal event. The average onset is 2 to 21 days after exposure. The average is 8 to 10 days. The further out you get from that middle range of 8 to 10 days, the less likely you are to go on to develop symptomatic illness. There's been concern in the press about how do we tell Ebola from flu. Fortunately, they are different illnesses and they present differently. Flu initially has nonspecific symptoms, headache, fever, runny nose. That's very different from Ebola, which has fever, which is usually fairly high, but not necessarily. Headache, which is usually severe, but an absence of respiratory symptoms. Influenza is contagious right from the get-go. Ebola is not contagious until symptoms have firmly set in. The reason for that is because the amount of virus present in the body early in the symptomatic phase is too low for the illness to be transmissible. In fact, it's so low that the initial test for Ebola virus frequently is falsely negative when symptoms first present. And so if you're tested for Ebola and get a negative, you don't accept that as disease absent until you've redrawn blood and retested 3 days later when the viral titers typically are higher. So when the symptoms initially present, even before then, there really is no risk of transmission. Here's a scary graph showing cumulative cases through the 26th of this month. It just climbs and skyrockets. Here are the case counts as of today, with some 16,933 deaths, 6,002 deaths, and 16,933 cases. These are cases with confirmation. There are undoubtedly many more cases in these countries that we're not aware of and don't have records of. I'll note that some 592 healthcare workers became infected, and about 60% of those healthcare workers have died. The healthcare workers who became infected did not become infected typically in the clinics, the specialized clinics providing care to Ebola patients. There, the physician and other healthcare worker knows what they're dealing with, uses personal protective gear, and only infrequently has an accident or break in technique that leads to disease. The people who became sick are the healthcare workers in their private offices or in the standard hospital, taking care of patients that they thought had typhoid fever or malaria or any of the other typical febrile illnesses associated with vomiting and diarrhea, and didn't find out that it was Ebola until after they had become infected. For this reason, most of the typical standard hospitals in these countries are closed because there aren't any healthcare workers to staff them. Here is a model of the progression of Ebola. You'll note it starts in December of 2013, which is when the first case in this outbreak occurred, and climbs. The darker blue is through today. The lighter blue is the projection through on into early January if our efforts to control this disease in West Africa remain as they are now. If our efforts deteriorate, the graph becomes even steeper. If we increase our efforts, it's possible that the graph could come down and start to plateau, but as of right now, there's not any suggestion that the outbreak is plateauing. How is it spread? It's spread through direct contact with body fluids from a person who is currently showing symptoms of and is sick with Ebola. This means blood, sweat, basically any body fluid that you can think of. As the illness progresses, in the fatal case, the amount of virus in the system continues to increase right on through death. And at death, viral titers are extremely high. And unfortunately, at death, the body becomes very poor at containing its fluids, and so it's easy to transmit Ebola from the deceased patient. It is not a respiratory disease. It's simply not spread by the airborne route. And by airborne route, I'm talking about things like flu or influenza or measles, which is very easily spread by the airborne route. Burial practices are very important. There's a cutout at the bottom from the World Health Organization's recommendations about providing dignified burial for victims of Ebola disease. But the estimate is that about 20% of new cases in West Africa come from burial practices, traditional burial practices. And this is interesting if you like statistics and like case investigations. This case really is, this outbreak, the whole of this outbreak is traceable back to a 2-year-old boy in Guinea who on December 26th of 2013 fell ill with an illness characterized by fever and vomiting. He died 2 days later. Subsequent investigation has shown that there were about 4 different trails of illness from this, but every case that's currently happening in West Africa is ultimately traceable back to this initial outbreak. There is widespread fear of Ebola viral disease spread, and I've heard, well, what if someone coughs on you or sneezes on you? First of all, people ill with Ebola viral disease in the United States are hospitalized, so they're not out in public where they can give it to you. Secondly, people incubating Ebola viral disease who do not yet have symptoms can't give it to you by cough or by sneeze. People with early symptomatic Ebola viral disease also probably can't give it to you by this route because their viral titers are, again, very, very low. The titers don't rise until after symptoms have gotten fairly well established. And another fear is Ebola becoming airborne. Ebola does mutate. All viruses mutate as they go through their replication cycles, but it's actually unlikely to develop a brand new, for it, mode of transmission, since it's very successful now, evolutionary speaking, being transmitted by body fluids and by its current techniques. So there is no evidence over the past 40 years of Ebola being transmitted by the airborne route, and that's just the way that it is. We know that it's not airborne. These are some photos of markets in Africa, not necessarily the countries involved, but the markets are incredibly crowded. And if Ebola could be spread by a cough or a sneeze, then we'd have a lot more people sick with Ebola than we currently do. As bad as the outbreak is, of course it would be worse if it were easily transmissible by the airborne route. Are we prepared? Local hospitals have been working to prepare for months. I really have to speak highly for the local Valley Health Hospital system. They were on board with this in September. They actually came up with their own guidance for personal protective equipment that exceeded the CDC's initial recommendations and actually exceed the CDC's current recommendations. Set up a very nice system to handle a patient if we have a patient here. Every hospital in this health district is prepared to do the initial isolation and stabilization of a patient with Ebola viral disease. And Winchester Medical Center is fully prepared to manage as many as 2 through the entire course of the illness. In Virginia, UVA and VCU are the designated Ebola viral disease treatment hospitals. If we were to see a case come into Virginia, the initial step would be to try and transfer that patient to one of the biocontainment unit facilities in the country, but there are only 3 of those that are around for Ebola viral disease, and collectively they've got 6 beds. So it's easy to imagine a situation where it would be impractical to transfer a patient to such a place, which is why we've established, now we have 35 and they're working on 53 hospitals across the country who have been pre-designated and looked at by the CDC to be sure that they're up to snuff as far as taking care of Ebola viral disease goes. And we already mentioned 2 of them. So there are 3 biocontainment facilities. There's one at Emory, there's one at Nebraska Medical Center, and there's one at the National Institute of Health here in Maryland. In small print, I put St. Patrick Hospital in Montana. It actually has a small biocontainment unit, but it's there for a specific reason to respond to a problem at a research facility nearby. So it's not a standard ready to go for the general public biocontainment unit. 35 state designated Ebola treatment centers exist. I've listed the ones that are nearby, the ones in Virginia, DC, and Maryland on this slide. So I feel like we've got the capacity to take care of patients with Ebola viral disease should they present. Now, returning travelers. This is the other side of the coin in figuring out who we have to worry about, who we don't have to worry about, and what happens if someone does develop symptoms. Beginning in October, all travelers returning from Guinea, Liberia, and Sierra Leone were required to enter the U.S. through one of 5 designated airports, and of course Dulles is one of those 5. I'll do it wrong again. Mali, thank you, was added to the list on November 17th. When you arrive, if fever or other Ebola symptoms are found in a traveler, the CDC assesses that and arranges that the patient be transferred to a hospital where they can be isolated while they're tested for Ebola and also tested for other common causes of fever in the returned traveler and are treated for their symptoms. Excuse me. Travelers with no fever and no symptoms are allowed to go on to their destination, safely so, because they have no symptoms. They can't give anything to anybody. They aren't sick. And then the information about the traveler is transmitted to the local health department at the traveler's destination, and the local health department begins what is known as active monitoring. So, active monitoring. Returning travelers are grouped into one of 4 groups in general. Those that are sick on arrival are taken to the hospital. Those who are not sick on arrival but have some sort of a travel history to put them at some level of risk are divided into one of 3 risk categories based on the exposure history they report. So if you came in and said that, oh, I was taking care of a patient in Liberia and I stuck myself with a needle, but I feel fine, you would be put in the high-risk exposure group. If you've been to one of the countries but have no recognized exposure, then you're placed into the low but not zero risk group. And the monitoring that's done depends on the level of risk. Active monitoring is the lowest level of monitoring that we do. Everybody coming back receives active monitoring. Active monitoring means that the person who has traveled takes their temperature twice a day and records on a log sheet their temperature and presence or absence of any symptoms that would be compatible with Ebola viral disease. The health department communicates with that traveler every single day to monitor the situation, to A, if symptoms develop, arrange for prompt, rapid, safe transfer to a hospital isolation unit for evaluation and treatment. So that's how active monitoring works. Direct active monitoring is a step higher than that, where not only does the health department contact the traveler every single day They also have a eyes-on contact with that traveler every single day, just to ensure that we know they're where they say they are. We know that they're looking healthy. We know because we've seen them. Quarantine and isolation comes up as a question. Why don't we quarantine everybody? Well, there are some thousand people being monitored right now. It would be pretty hard to quarantine everybody. Right now in Virginia, we are monitoring between 75 and 85 returned travelers. And I, again, want to stress that these returned travelers are not sick. They may have had some level of possible exposure, so there is some level of risk that they may develop Ebola. But in the absence of developing Ebola, there is no risk. So, quarantine separates and restricts the movement of people who were exposed and provides some level of control so that we know what is going on. So quarantine is used for people who are well. Isolation is the word that refers to how you manage a person who is sick with a contagious disease. A person with Ebola viral disease who is sick is isolated in the hospital so that they cannot spread infection to anyone else. And again, I stress, nobody with Ebola viral disease, even if they're incubating it, presents any risk to anyone until after symptoms have developed. So everyone returning from the affected countries is being actively monitored. So I can tell you who and where everybody in my health district is right now that we're monitoring. I could tell you, but I won't tell you, because we consider that protected health information. So, how is it enforced? In Virginia, and I can only speak to Virginia, we are required by the Code of Virginia to try the least restrictive form of monitoring first. And we can only accelerate beyond that if the behavior of the subject demonstrates that it is necessary to protect public health to move beyond that. The commissioner can issue an order of quarantine or an order of isolation, and the commissioner stands absolutely ready to do so if it's necessary. Even though the order is issued and can be enforced by the police, it's a legal order, there is essentially an automatic appeal to the court, and the court then reviews the situation and will either uphold the order or cancel it. So, that's how it works. The keys to controlling an Ebola viral disease outbreak are first recognition that the person is sick. If you don't recognize that they're sick, or you think they're sick with something else, but they actually have Ebola viral disease, that's where outbreaks spread, and they can spread rapidly, as we've seen in West Africa. Prompt isolation of the ill person is very important. First, to provide appropriate treatment to the person sick with Ebola viral disease, but also to protect the community. Contact tracing is important because we have to identify contacts of the person ill with Ebola viral disease so that we can subsequently monitor them so that if they should develop symptoms, they'll be recognized and promptly removed to isolation. And of course, education, which we're trying to do tonight. Contact investigation is one of the long-time big duties of the health department. We do it every day with sexually transmitted infections. We do it every day, well, not quite every day in this district, fortunately, for tuberculosis. We do contact investigation, that's what we do. And contact investigation is how we would control an outbreak in this country. And it is how they successfully controlled the outbreak in Nigeria and in Senegal by identifying everybody at risk and monitoring them closely so that if they develop symptoms, they could be immediately isolated. So the goal is to stop Ebola from spreading. There's always a top 10 countdown. Your dog and cat is not going to spread Ebola. just subjectively speaking, it looks like this is primarily a disease of primates. We're primates. And there are not piles and piles of dead dogs and cats in the affected countries. They seem to survive and not get sick. Food and drinks imported from West Africa are safe. Mosquitoes don't carry Ebola. They carry lots of things you don't want to get, but they don't carry Ebola. Persons returning from countries with Ebola outbreaks present absolutely no danger to you. This is coffee. You can't survive without it. Household bleach and basically any disinfectant kills the Ebola virus. It is not a very hardy virus. If you're feeling sick tonight, think flu. Don't think Ebola. And if you haven't had your flu shot, please go and get it. Ebola is not airborne. Ebola does not threaten the safety of air travel. Ebola is only spread person to person after symptoms begin, and you can't get Ebola from a handshake or a hug. I imagine, well, no, I won't say that. It's the public event. So how's it spread? Just like the picture. They are working on vaccines. Actually, the initial work on vaccines for Ebola did not come out of concern for human illness. It arose out of concern for the numbers of gorillas dying from Ebola every year. As it happens, we are primates, so the vaccine appears to be safe. It's been tested in humans and appears to be safe. We don't know yet if it provides effective protection, but I think that we'll probably have a vaccine, at least I'm hopeful, before too long. And there actually are already 10,000 vials of it available, so it can be moved out and used once it's been shown to be safe and effective. So those are the two vaccines that are being worked on. Not really very interesting. There is no FDA-approved vaccine or medicine at the current time. There is also no approved curative therapy for Ebola at the current time. The mainstays are providing intravenous fluids and balancing the body's electrolytes, maintaining the oxygen status of the patient, and treating other infections as they occur. Basically, you support the patient, you optimize their fluid balance situation, and you hope that their immune system will win the battle. Typically, 6, 7, 8 days after symptoms manifest, the patient will start to get better or will continue to get worse. If they continue to get worse, the outcome is almost always fatal. But if they turn the corner and start to get better, then they go on to recover. And those who've recovered have antibodies, so they probably are immune to at least that strain of Ebola that they had for some period of time. How to prevent it: avoid infected people, avoid body fluids, and avoid the bodies of anyone who's died from the disease. And there's a whole bit of work in the background to ensure that any person who dies of Ebola in a hospital in America is handled appropriately so as to protect everyone. In Africa, you should avoid contact with wild animals like bats and monkeys and with their meat. In the U.S., you should avoid contact with wild animals, not because of Ebola, but because of rabies. You want to wash your hands often, and after you leave, you watch for symptoms. So anyway, that's basically, thank you. I'm done. Nobody came out with a hook.
Thank you, Charlie. That was great. I'd like to invite the panel up to take these seats, and then we'll have a few comments from the panel members, and then I really want to open it up to the audience, who are slightly more than the number of panel members, so that's great. But it means we can really interact. It is. This one's on. So Ron, I don't know if you would like to start off by saying a few words on what Shenandoah University has been doing in terms of putting in place policies and procedures to protect not just the students, but also the faculty and staff as well.
Good evening, I'm Ron Stickley with the Wilkins Wellness Center here on campus. we started working on our policy back in the midsummer. We saw a need for it because we have a very diverse population here with many international students. We also do a lot of international travel. So the reason we started with this was because wasn't so much worried about in August, but more so when our students returned in January. But we also went through and checked. We do not have any students that are from any of the 4 affected countries. So that made me feel a lot better. But when we created our policy, which was done on August the 3rd, October 3rd, the Center for Disease and Control came out with the guidelines for ambulatory care clinics, such as the student health clinic here at the university, urgent care clinics, med clinics, things like that. And our policy matched their recommendations 100%. So we felt a lot better with what we did. We also got enough equipment to supply 2 rooms that are in our health clinic in case we have a patient that would happen to come in. Secondly, we have additional equipment down in the School of Nursing and also for our Leesburg campus down in Schuyler Drive. So we are ready, and our biggest thing, what we will do is identify, contain, and then once notification's been made to the health department, to the hospital, to local fire rescue, then we will transport when everybody is in place. We will not send someone into the ER without them knowing it. If it would come down to where one of our students would be sick in one of our residential halls or in one of our classrooms that would be identified, then we would quarantine that particular area until health department again comes in and takes the lead on the next steps. So our policy matches what we need to do. It's been signed off and approved by the hospital, the health department, and like I said, matches the Center for Disease and Control. So the biggest thing we can do this winter is tell people to keep washing their hands and stay away from the 4 countries unless you have a medical need or legal need to go there.
Great, thank you, Ron. Kathy, do you have a few comments?
Sure. I'm Kathy Gansky. I'm the Dean of the School of Nursing, and I was watching what was going on like all of you were, and speaking with Ron, and it quickly occurred to me that, first of all, in any situation like this, whether it's Ebola or some other infectious disease, or any problem where someone is sick and needs care, nurses are on the front line of caring for folks. And so you could see very well in the media what was happening to the nursing staff in the hospital, especially in Dallas. And there was lots of misinformation, but also what was becoming clear was our ways of managing other infectious diseases were different than what was needed now. So we needed to ramp up the training of our students, and that was my primary concern. I contacted Gilda, who is one of our lab coordinators here, and in our beautiful labs, and by the way, happy to give you a tour in our new building. But I said, Gilda, we really need to make sure that our students have exactly what they need before they go into clinical experiences as students, and then so that they'll know what they need as practicing nurses. And so that's what she did, and what I'm going to do is turn this over to Gilda to describe what she did to find the right equipment, and then what she's doing now with that equipment with students.
Thank you, Kathy. Again, I'm Gilda Gilbert, and I was really honored to have Kathy ask me. Infection control is an interest of mine, being a perioperative nurse since 1985. As far as understanding the transmission of organisms and where those boundaries lie, I do kind of lie in the expert realm there. But I have to say, Kathy and Ron both contacted me about the same time, and I really need to give kudos to Ron for being very proactive. When he initially contacted me, his policies were already in place. It was late in October, and we then were invited to come to Valley Health and discuss with them what they had in place, talk about how it affected clinics. They worked collaboratively to develop a plan for a transfer, and it has been an ongoing process. But for the role that I have had, the goal was not to necessarily to have our students be competent with donning and doffing PPE, because as students, they're not going to be placed in the role of caregiver in a hospital or clinic. However, they already serve as resources for their peers, for patients that they're taking care of, for their family members, neighbors. We want those students to have the most accurate evidence-based information that's available, because we know that there's a lot of information out there that is not. So what we've done is we have a PowerPoint that was developed having very similar content as Dr. Devine's, pulling strongly from the CDC and the World Health Organization. And then part 2 of their educational program is actually donning and doffing PPE. This takes about 40 minutes to completely dress a nurse, and that's aside from any care they provide. When they, we actually have volunteers, student volunteers, who come forward. It requires 2 people to don and doff. One is a trained observer who uses a checklist very similar to what you would see a pilot use in the aviation system. Every box must be checked. Attention to detail is huge. The person who's the trained observer is wearing PPE as well. And there are there are virtually thousands of different items of PPE that are available out there, personal protective equipment. So what Ron was really helpful in doing is he did the research for what is appropriate for confining a person who would walk into his wellness clinic, and made those items available for the School of Nursing. Some of those are very similar to what we use for contact isolation patients. Then Valley Health shared their protocol with us for the level 4 contagion response. So we have put together a recipe, so to speak, for meeting that criteria. It might not look like everybody else's, but our students then get the opportunity to put this PPE on, and it's not cool under there, just let me tell you. That is one of the biggest responses that we have from our students is, I'm really hot and I haven't even done anything, and then this is a huge awakening for them, because they begin to critically think, how would I provide care for a patient? If my patient had an extreme emergency, I couldn't just rush into the room. It takes a significant amount of time. Every step is crucial to don and doff. So all care has to be orchestrated, planned over time. You cluster what you do for a patient. You plan how often you go in, and you make sure that everything is done. So getting them acquainted with that type of care, which is very different than their hands-on care that they traditionally are taught. That's the goal that we have.
That's great, thank you. Obviously we have considerable expertise on the panel, but none of us have recently just come back from West Africa. And I've got a suspicion there'll be questions about that and what that experience is like. I don't know if you would like to say a few words before we solicit questions?
Actually, if you don't mind, I will. One of the things I have with me is my CDC kit, and that's what they call it when you come through the airport. I also have my step-by-step guide for my staff on what's going to happen from the minute they leave Africa to the time they walk in their door. But if you don't mind, I'm going to jump in with a couple of things about this so that you have some perspective. First, my name is Maggie Burke, and I'm Director of Operations of an international development organization called IBI International. Everyone that works in West Africa is not a humanitarian doctor or nurse. There are many other people that work there. The oil companies are there. Firestone, which was one of the first organizations to respond to Ebola successfully on an enormous rubber plantation, is there in Liberia. My organization works in 45 countries, or has worked in 45 countries. We have operations in Liberia. We work under contracts with the State Department and USAID, and we work in 17 ministries on a government level, working with them in various parts of financial development, human resources development. There's a lot more involved in many of the developing world beyond what you see in humanitarian areas. Prior to being with IBI, I worked in the humanitarian field for 20 years. I was a director of management services at Africare, where I spent a great portion of my time in Africa. And for 7 years, I was vice president of an organization called ACDI VOCA. I have traveled enough to Africa that I actually have 2 active passports, 2 State Department issued active passports. So I travel often, and I travel beyond Africa, but I've spent time in refugee camps in Chad. I've been in Haiti right after the earthquake. I've been in Indonesia after the tsunami. I was, as vice president of administration at ACDI VOCA, I was managing the organization when SARS came through, and we had travelers going back and forth. I had to make a decision. Well, actually, I didn't have to make a decision. I volunteered as the decision was being made to send somebody to Liberia. We needed to send somebody from the home office to go there. And part of my job was actually developing the contagious disease policy for our home office, also managing our 70 plus employees that are in Liberia. We have about 20 expats and third country nationals, expats being US nationals, and 60 local nationals. And these are people who are living in the communities where the Ebola outbreak is happening. So when we made that decision, I volunteered. I decided I was going to be the one that was going to go, because we had some of our staff who was in the panic phase. Oh my God, nobody can go. And we had other people that were, well, I'm not sure. You know, I'm in front, I will be stoic and tell you, sure, I'll go, but if you get to the point where you want to put me on the plane, I might change my mind. I come from a family where my mother, sister, and daughter are nurses. My mother was an infection control nurse epidemiologist during the AIDS outbreak, before it was called AIDS. So our dinner table conversation was staph infections, AIDS, meningitis, just about anything you could come up with, where most of our kids would go, ooh, that's gross. We would sit and talk about it at the table. And my father was an engineer, so he was very, got to do fact. We got science and engineering, and everything has to be fact-based. I had learned enough about Ebola from managing the operations of our organization, which included human resources. I also am heavily involved in the security of our organization and have been involved in security for about 20 years of aid workers. If you Google me, that's the kind of stuff that will pop up. I decided I was the right one to go, so I went. When you get to the Brussels airport, you're sitting at the airport, and people are comparing what they have in their Ebola kits before you get on the flight. And there's this very kind of tense camaraderie, everybody's talking, everybody's joking. A flight can actually hold 179 people, and it was almost a full flight. Half of the plane were Liberians that were going home. The other half were a mix of humanitarians, security people, and people like me, who were going to Liberia for business reasons. If you don't need to go, I don't recommend going. But from the minute you step off the plane, the smell of bleach is everywhere. And that's how they're in the process of fighting it. You wash your hands. You can't walk into any building without washing your hands. You don't get into a car, into a vehicle. You don't do anything without somebody checking your temperature. I actually, on a daily basis, proudly wore all of my temperature tags every day, wherever I went. I had temperature tags on me because you would go into a place, the Ministry of Health started this in Liberia, where before you go in the building, you have your temperature taken, it's written down, the person initials it, puts the time, the day, and it goes on your clothing. And after we're done, and later I can pull one out and show you what they look like. I think I have one in my packet here. Then you go to, if you need to go to a shop, expats and third country nationals shop in what looks like a small 7-Eleven style grocery store. It's a very tiny grocery store. You're checked and you wash your hands with bleach. There's signs everywhere. You cannot drive in Monrovia, go around Monrovia, go to and from the airport, go anywhere without big signs about Ebola, reminding you that it's present. And while we see the statistics that Dr. Devine put up there, yes, there are 7,000 people who have succumbed to Ebola. But in Liberia, there's 4.29 million people who haven't had it. And that's something we need to think about. As we hear the fear and panic on our news that happened before the election, and when I look in the room here, I can tell you that had we had this program before November 11th, this room would have been standing room only. But since November 11th, the news puts blips, little blips. 30 seconds, here's a little bit about Ebola. Prior to November 11th, CNN was jokingly referred to as the Ebola channel because it was Ebola all the time. And everybody really did believe that the zombie apocalypse was coming. That people with Ebola were going to walk around and embrace you and give you Ebola. But if any of you have had the flu, you know when you get a fever, there's no way you're going to get up and walk around trying to infect other people. You're too sick. So these are some of the things that you deal with. When you get on the ground, you go, wow, it is nothing like the news has been talking about. People are moving about. They're not touching. They're cognizant of the 3-foot rule, even before the 3-foot rule became apparent with the CDC. Everybody understood that. You don't see people congregating in large groups. Even the children, when they're playing, if you watch them, and it's very hard to tell a child not to play, what you do see is more of the non-contact sport type of thing that they're dealing with. They may kick a ball around with each other, but you don't see them wrestling or playing tag or anything like that. And that's where the greatest fear of exposure is, at least for my people, is when their families go home at night. In July, I said something very profound to my sister. My sister, who has done humanitarian nursing in the field, in Nepal and in the Philippines, said, why are you going to Liberia? Why is it you? And my response is, if not me, who? Am I going to leave it to somebody else to control what happens? I have the wherewithal to go ahead and do it. I'm going to go ahead and go. But I also felt the need to go to see what was actually going on the ground and to actually walk through it so I could speak to my staff about their experiences when they came home. When I left, the news was at the height of the zombie apocalypse. And I left it actually at the end of October. And when I left, it was just horrible. And I was really questioning myself, was I going to get on the plane? Right up into the point that I got on the plane. Once I got there, I had this big sigh of relief going, oh, I can do this. I can control my environment. I have drivers, I have a self-contained office like most people do. Everything is done inside compounds unless you live in the villages. It's in a compound. I knew not to go near anybody that had a fever or temperature. I wasn't going into any of the hospitals. I didn't run around with these giant security teams that you'll see the news crews run around with that they don't show you. I wasn't in an environment where what you saw was the same picture of the same person 50 different ways in an effort to show you that the world was coming to an end. So I got on the plane and I came back. That was my greatest fear when I left. When I left, I was not as afraid of what was going to happen when I got there. I was afraid about what was going to happen when I got back. And I live in Frederick County, and I apologize. I'm going to tell you what I said to a friend of mine. I live on a farm in Frederick County. I have lived here for quite some time. My significant other's family has been here for 200 years. And I joked to a friend of mine and said, I'm really, really concerned about what's going to happen when I get back. I have visions of Marty McFly getting out of a DeLorean with a white suit on, and one of my neighbors going, Martha, go get the shotgun, the aliens are here. I wasn't sure even how the health department would act, and that's because of what happened with Casey Hickox, who we all know very well at this point. And so I went with lots of ammo. I had read HIPAA inside and out. I'm a George Mason trained paralegal. I've been working on the legal side for a very long time, so I got to know HIPAA inside and out. I got to know why the media was giving out names. Do you ever wonder that? You wonder why? Okay, isn't there any privacy? So I learned about the ethics. I got into that part of the ethics. I got into the ethics of how do I deal with my employees and how do I deal with myself when I come back. There's a whole ethics of business. So I had to learn about the AIDS epidemic all over again and how a lot of our laws changed surrounding that. So when I got off the plane, I was ready. I got off the plane, I was like, okay, they're gonna know I'm on this plane. And I already knew at least 5 other people on that flight were on my flight. And I knew them because they were in a security meeting that I had gone to earlier in the week. None of us talked about Liberia. We got into Brussels, we all got off the Liberia flight. And by the way, 12,000 people have flown on SN Brussels Air. And that's a number that was given by their CEO in a speech. 12,000. And no one has shown up on one of their flights with Ebola. No one. And that's because before you get to the Monrovia Airport, before you can get out of your vehicle, before you can drive up to the front gate, your temperature is taken. Everyone in the car has their temperature taken. You get up to the front door, you're given Ebola handouts. They talk to you about Ebola. Then you see a security guard. The security guard points over and has you wash your hands with bleach. And you see people washing their hands and faces and everything they can with bleach. Everybody has their own ink pen. Nobody touches anybody else. Then you walk up to a nurse assistant who does the pre-screening. Then she sends you to a nurse. Then the nurse checks your temperature. She asks you a series of questions to see if they match the questionnaire that you filled out, that you've all heard about, if you've heard about the name of Duncan. He filled out that questionnaire as well. And that questionnaire does ask, have you been in touch with anybody? Have you done this? There's a lot of questions. Then you sit in the waiting area after your luggage is checked. You cannot get on board without a hand check of your luggage. You cannot have anything frozen. You cannot have any food. You cannot have any liquids, nothing in your checked luggage or your handheld. You can have clothes, papers, a laptop. Nothing organic can be in any of those items because they don't want you bringing bushmeat or other things back on the plane. Before you get on the plane, there are nurses and medical teams standing right at the doorways because you don't use a jetway in these countries. You have to walk out to the tarmac and walk up the high steps. There are nurses and medical teams there screening you again. Brussels Air has turned away 7 people during the period of this Ebola outbreak due to fevers. But they will not let you get on, and they do check you. And you're under surveillance from the point that you drive to the airport to the time. Think of Dulles Airport parking. This is before you even get to parking, you're out there. You get on the plane, you fly, you sit down and you go, I hope that person next to me doesn't have the flu. Should I check if they have a fever? Because everyone has a thermometer. I guarantee everyone on that flight has a thermometer stashed away somewhere. You pull out your wet wipes that have chlorine bleach and you start wiping everything down. You get on the plane and you get to Brussels. Everybody talks on the plane. We walk around, get to know each other. But when you get off in Brussels, you start down the jetway and you get to the end of the jetway. Don't think you're going anywhere that quickly. The plane is parked very far from the main part of the terminal. And they are there screening you again. So you've been on an 8-hour flight, you're getting screened again, you get off. Now you can go through the airport and go to your flight. You go through Brussels Airport, they already know who you are before you get on the plane. There's no question that they notice. You get on the plane, don't say anything. There was a woman sitting behind me who had worked for a humanitarian organization who started going on and on and on and on. I don't understand what all the panic is in the United States about Liberia. I've been here for several weeks and she's going on and on and on and on, and the person sitting next to her got up and asked the flight attendant if she could be moved. But 2 seats over from her, there was a lawyer, and he decided he wanted to sit and listen. So he started talking to her and struck up a conversation. But a lot of us who had been in the security field or had traveled extensively knew you don't tell people who you are. You don't tell them what you're doing. You don't express that information. You don't need everyone around you to panic. Don't give them a reason to panic. Because there are people who believe in the zombie apocalypse. So you get off the flight here in the United States, you go through Customs and Border Patrol, you do your passport, you walk up to the immigration officer, you hand him your passport, and he looks and he nicely says, so what countries have you visited? It's on a customs form. He goes, I know, but I had to ask anyway. Can you step over this way? So the people who were on my flight, who came in, and by the way, we were coming in with people from Pakistan, and there was a flight from China. Everybody's smashed into this area. Have you heard of anybody getting Ebola at the airport yet? No. Now we're standing on the side. I can't tell you how nice this went. I was really surprised. And I've had a colleague of mine who has been back since, and she's only had one hiccup. The supervisor from immigration took my baggage check, took the baggage check of everybody in our group, walked us over to the screening area. They got our luggage. I didn't have to worry about it. We sat in the screening area. There's either a paramedic or a CNA or someone there who I'm assuming is a contractor, takes your temperature, writes it on a form, has you sit down, and then you get to go through the next part of the process, which is they start asking you the questions because they want to know which of the levels that you fit in that Dr. Devine was talking about. And when you go through this, you're given this numbered envelope, because I guess they want to make sure that they give you the right envelope, and they want to be able to track the information that they gave you. And the envelope has a small card you can carry in your wallet. For me, I was low but no risk, low but less than zero risk, because I had been there. Low but not zero, there we go, see, this is important. And in this, I have all the phone numbers for all the states' health departments. I have Ebola care information. That's given to you. You're given your own thermometer. You're given posters on Ebola and a poster that's similar to the one that you saw previously. So you're given all this information, and you're also given this form, or this paper. It's a symptom card and log, and you have this. You fill it out every day, and you go through each day, and you write down if you have had any symptoms and what your temperature is. And this way you can have a log. And then for me, I have the nurse manager's number, the epidemiologist's number. I have everybody's number here that I would need to call if I had a symptom. I was not put in quarantine. I did put myself in self-isolation, which means I decided to telework for 21 days because no matter what scientific information I had, the fact that I knew I had a very controlled environment, I always said, what if? What if everybody's wrong? What if I'm wrong? I wanted to make sure that I had that information handy just in case. And I wanted to stay where I was in isolation. And I never had anybody show up in any nuclear suits or the PPEs. I was very, very lucky. This health department is far beyond, I mean, their knowledge is far beyond what some health departments are. I was very, very happy with my visit. Nurse manager came, epidemiologist came, they stayed outside like they're supposed to, they kept the 3-foot distance like they're supposed to. But I had an opportunity to show them a couple of quick pictures on my cell phone that I had taken of Liberia while I was there. I got to show them my kit. They had not seen the kit before. And I got to do my 21 days with a group with Dr. Devine and with the epidemiologist and nurse manager that were highly knowledgeable. They knew the facts surrounding the disease, and I'm off my 21 days, so before you leave, if you feel brave, you're welcome to come up and give me a hug. It's okay. Even if I was in my 21 days, you could, because I took my temperature every day, twice a day, on a regular basis. I checked in. I didn't feel it was invasive. They did respect my privacy. Oh, tremendously. Dr. Devine brought that up before I came tonight. I didn't tell anybody your name, and he said they have kept my information private, and that's because I know that there are some people that just think that watching TV will give it to you. And it's unfortunate, but we do live in a society where that happens. We get so much on the news that we think is real. But the team was very knowledgeable. I actually have my letter on the way that tells me I've been released, and today on my way home from the office I was thinking, gee, I need to have one of those Ebola parties they have. They actually have these in Liberia, Sierra Leone, and Guinea when people become Ebola free, when they've survived the disease. They get to the other side, they have a certificate and a party just for them because they don't have the Ebola disease. And I thought, wow, this is great. I've actually gotten to that point. So, but I really, they understood HIPAA early, and the reason I wanted to raise that is because that's the hiccup of my colleague. My colleague is in a major metropolitan area in Virginia, and the nurse that she saw, her very first visit, when she said, can you tell me about what my privacy rights are? I'm giving you all this information. I gave all this information. And she went, well, you don't have any privacy. This is a contagious disease. So she went outside. She was texting me, and I texted her back, and I said, you don't have a contagious disease. You need to go back in and talk to a supervisor, because, and then if they don't know, you need to tell them to call the Attorney General in Virginia and ask him what he thinks. But she was actually told that. So there is a difference depending on where you are as to the knowledge base. And finally, someone did come someone did say that they had to call the CDC. And they did tell her that, yes, she does have privacy rights involved unless she becomes contagious, and they have to do contact tracing, and went through the whole thing. But and then you don't, right, then you don't reveal the contact. Right, and I actually had a friend 30 years ago who had AIDS, and I was one of the many people that they contacted, and they wouldn't tell me who it was back then. So they're following a lot of the same protocols that were actually developed during that. Thank you.
That's great. Thank you so much. Wonderfully informative and completely unexpected. Thank you, Charlie, for this wonderful guest.
Thanks to the guest for agreeing to come and speak with you.
Absolutely. Let me open it up to the audience. I'm sure you have some questions. I will walk around with a microphone.
When they take your temperature at all these different times, do they use a regular thermometer or is an infrared thermometer?
That's actually a good question. One of the things that I got into a habit with is when I got here, I was given an oral thermometer, and I kept checking it against my infrared thermometer. But they check you with an infrared thermometer because there's no touching all the entire way. There's no throwing away of the little plastic covers that go over the oral thermometers. And the oral thermometer that you're given here is it's one of the few things the federal government will give you free when you travel to West Africa, is you get your own oral thermometer to keep, and to actually, this information tells you not to share it. And then they also, rather than checking here, I have to take my glasses off, and all along the way they always check the temple.
You have an artery, the temporal artery right here, and so you get a more consistent and repeatable temperature reading here rather than the frontal part of your face. And then there's a different scale as to what you consider normal. So you consider 96 normal at the mouth, you might consider something higher normal if you check at the bottom end, and there's a separate scale for what you consider normal when you take a temperature on the temple.
Thank you. One follow-up. You said that after a period of time, let's say you are contagious, you have symptoms, and the disease will either play out to a point where you don't get any worse or you do get worse. For the people that don't get any, that recover of their own volition, is there any study to say what it is, what is symptomatic with all these people, or what is similar that these people, what is it that allows these people to survive as opposed to not survive?
It is their immune system being able to mount an effective response and fight off the virus. The virus is actually fascinating to study. It has the ability to produce proteins which confuse and confound. They act as decoys that confuse and confound the immune system. And so the person who survives is the person whose immune system is up to the job of killing off the virus. The person who doesn't survive either dies from dehydration or electrolyte abnormalities fairly early in the course after the vomiting and diarrhea starts, or if their fluids are corrected and balanced, they go on to die later from what looks like a sepsis syndrome. The infection becomes so overwhelming that the liver fails, the body's clotting system fails, basically everything fails. But the difference in the survivors and the non-survivors is the ability of the immune system to successfully fight off the infection.
Other questions?
You mentioned earlier the 2-year-old, the origin case in this particular outbreak. Are there any ideas or any indicators where he got it? And why does Ebola surface and then hides for a period of time and keeps coming back and coming back?
No, those are two very good questions. Unfortunately, nobody really knows. The 2-year-olds Right, where the 2-year-old acquired the illness is not known. It's presumed that perhaps he interacted with meat that was being prepared to be bushmeat, or perhaps ate fruit that a infected fruit bat had left droppings on or left saliva on. But nobody really knows for sure as to why it pops up and flares and then goes away. Typically, this is scientific surmising. The virus gets into a human who interacts with a bat or interacts with bushmeat or somehow acquires it. They become ill with vomiting and diarrhea. Infected are the care provider, the mother, the father, who are trying to care for the ill person, the wife, the husband. Whoever is actually doing the hands-on care gets sick because they're interacting with the viral-laden body fluids. Family members who don't provide hands-on care don't get sick. So it's the care providers who become sick. And then it spreads further because of the burial practices. Why does it not spread beyond the initial small village? Usually because people don't travel away from the village. So it doesn't get taken to a large city or to a place where there are lots of potential victims. In the index case here was in an area of the country that's very close to the borders of both Sierra Leone and Liberia. And so people who became infected were able to travel and move. And just by coincidence, this episode happened in an area that was able to spread it out and away before it burned itself out locally.
I also want to say that in the a lot of us don't have perspective of geography. You can fit the entire United States and South America and several other countries and even a continent or two in Africa. Africa is that big. Liberia is enormous as well. And when you're in Liberia, Guinea, Sierra Leone, people travel from village to village by taxi, and they're not like our taxis. That's where our cars go to die. They go there and they become taxis. And you may have a bus. People can't afford cars. So you'll see that people cannot just get in a car and go somewhere. They may get on a bus. And the bus is the size of a small VW bus, and you'll have 20 people, I'm not kidding when I say this, 20 people cramming into this little bus going from village to village, and that becomes a taxi. So MSF was thinking that might be part of the way that this was actually being transmitted, is that people were sick, they used these buses, they used these taxis to get to the Ebola treatment units, or ETUs, in Monrovia, and that's why Monrovia has a very high death rate, and part of it is because there are people coming from the hinterlands to Monrovia for medical care, because that's the only place there is medical care, and unfortunately that's where they end up dying. So it doesn't, it isn't necessarily that out in the boondocks there is nothing going on. It's just that a lot of people are migrating to these ETUs.
That's how the illness got to Mali also. Two separate introductions of sick people who sought treatment for what they thought was malaria or what they thought was typhoid crossed the border to treatment centers in Mali, remembering that all of the treatment centers in the affected countries have closed because all of the healthcare workers are deceased.
How long can the virus live on the hard surface or on the fruit?
Nobody really knows that for sure. If the virus is in a small drop of fluid, as soon as the fluid is evaporated, then the virus is no longer able to infect. If the virus is in a larger puddle of fluid, but is in sunlight, the ultraviolet light is very effective at making it no longer able to infect. If you were to put it in a vial, like a vial of blood, and then carefully set that away where it's dark and the temperature is controlled, it probably could survive for some weeks, but it takes an ideal circumstance for it to be able to do that.
I was asked once, I work at the university here, if it could be put in a package. If someone was sending a package from there to someone here, could it live through that? Do you know if they're doing anything in the Postal Service to
I
track that?
don't know the answer to that.
As I mentioned, part of my area is security, is in the background of security. About 3 weeks ago, there was a small cooler with the blood of a man who had died in Guinea in the small cooler, wrapped in bubble wrap and put in with ice, and it was being transported by the Red Cross from one area into the capital to be tested because they were trying to find out if they had a new outbreak in a new village. And the vehicle was hijacked and robbed. And the Red Cross worker kept telling them what was in this cooler, and they took it anyway. And that has been a concern. The big thought has been is we've got this vial of blood out there, and of course now many governments have been looking at it thinking, okay, can ISIS or ISIL, whatever you want to call it today, could they use this actually as for bioterrorism? One of my certifications, which I took right after 9/11, is in bioterrorist warfare. So in managing that and trying to understand that. So I had a thought, even before all this was going on, I was like, one plane ride, it's all it takes. But you're right, is the Postal Service. And the Postal Service does look at everything. I can tell you when I ship back and forth from over there, everything is scanned before I get it. All of our packages are opened before we get them. So they would actually have to probably go to a third country before they came in here.
So it makes you wonder about the trade in exotic animals, doesn't it?
Well, that's true. The other thing is that a number of, I'm right on the edge of speculation, so I don't want to fall over and tell you a confabulated story, but I do know that mail going to certain government offices is irradiated. That is, they use high-powered X-rays, if you will, to sterilize anthrax spores or anything else that might be in it. To what extent that's used in this circumstance or for packages coming from West Africa, I certainly don't know the answer, and I'm not, certainly not in a position with a need to know, so nobody's going to tell me. But I imagine something like that might be happening.
Other questions?
I have a question about the vaccine. You were talking about like
Yes, ma'am.
10,000 doses. Can you
10,000 vials.
Vials. And so that is in the United States?
Yes.
And then can you talk a little bit about like the makeup of it? Like, would it be more of a vaccine or like an antidote?
No, it would be a vaccine to prevent. So you would not expect it to have any therapeutic effect on a person who was already sick. You would use this to prevent someone who was at risk of exposure from becoming sick. The technology behind, there are two different versions, and so I'm really only familiar with one of the two. The technology is really fascinating. They use a crippled adenovirus from a chimpanzee. That is, it's an adenovirus that is used to causing what is essentially a cold in chimpanzees. They have inserted into the genome the DNA instructions for it to make two of the proteins that appear on the surface of the Ebola virus. Those proteins on the surface are what trigger the body's immune response. And so you have this special virus that can infect humans, but has been crippled so that it can't reproduce in humans. But when it's introduced into the human, the cells that it does infect, it can't reproduce, so it doesn't go on to propagate. But the cells that it does infect receive the gene for making this protein, and so some of the protein is made, and that protein is seen as foreign, causes your body to make antibodies, and hypothetically anyway, you would be immune. The testing has gotten to the point where we know it's safe in humans. What we don't know yet is it effective?
And that was my next question is, what period of time would you need to get the vaccine and to have it be effective? Like with the influenza, it takes several weeks for it to.
Right, typically you'd expect it to take some time because your body has to develop its protective response. How much time or how many doses you might need over what period of time, that's not clear yet, because it's not even clear yet that while we know it produces an antibody response, we don't know that it's protective yet.
Ron, Kathy, or Gilda, is there anything that has happened in the last month or two that's changing the way we're sort of training not just our students, but also our folks that produce the meals for the students, people who look after the dormitories, and in terms of infection control, are you putting in place some new policies as a result?
The policies that we have in place are for all communicable diseases. This is just a slightly different version of all the rest. When you have cafeteria style food, there's no way to protect it 100%. That's why we're looking at putting hand sanitizers in the entrances to both the CAF and the student center here and things like that. But right now, we'll just follow our normal communicable disease policy.
Which is fairly protective.
It's protected is also broad. So we have to be open-minded and have our guidelines where we can expand them to suit the needs of what the next crisis will be.
That's the big question, isn't it? Is there one more question from the audience?
I don't know if this is actually going to be able to be answered, but I figure I'd go ahead and ask. Have there been any solutions thought of as to how to portray Ebola through the public, like for the public eye? I know you were saying how like after November 11th, Ebola kind of dissipated from being this big bad virus that everybody's afraid of. Are there any plans on how they're going to present whatever's next with Ebola and making it not such a fearful disease like, oh, that person next to me is going to sneeze on me and I'm going to die tomorrow, to make it so that it's not such a catastrophic, like it's clearly an issue, but it's not something that you're going to get, like you said, like you came back and you're fine. Are there any way, like, is the CDC connecting with the media? I know it's really hard to connect with the media on a realistic level, but are there any things set forth so that way they can change that?
The best we can do, we certainly can't control the media, and the media has a vested interest in inflating stories to bring eyes to their particular media product. So it's always going to be difficult to avoid sensational reporting because sensation brings eyes to media. What we're trying to do is provide actual factual information, which typically isn't spectacular, but is the truth. And we try and make sure that at each level, the CDC, I think they made some mistakes, but we try at different levels, the CDC all the way down to the health district, to provide a consistent message that is correct, that changes over time as what is correct changes over time. And by being available to talk, by being available with a consistent, true message, we try and counteract some of the sensationalism. But there's no magic.
This is actually the first of what we hope will be a series of truly interprofessional events that will hold both for the Shenandoah community but also for the Winchester community too. And we will try and be proactive and address any kind of health issues of that nature.
If I could, our generations are different. When in the 1970s, I'll give you some statistics here. Schools barred children who were HIV positive from attending classes. Funeral homes refused to accept the bodies. My mother, gowned up, as she referred to it, climbed up on a gurney in 1977 and held a man as he died from AIDS because no one else would go near him because they were afraid that just being in the room would give it to him. Gay men could simply be fired for being gay. Openly gay, closeted gay, if they thought you were gay, you would probably lose your job, and it was legal at the time. Families who had gay members of their family were also discriminated against. In the mid to late 1980s, a series of nationwide Los Angeles Times polls of people 18 and older, this is in the 1980s, 50% of those surveyed supported quarantines for people with AIDS. 29% favored, you ready, a tattoo for people who tested positive for AIDS. 42% of people favored the suspension of some civil liberties for those who tested positive. But it went beyond that. It went beyond just testing positive. And the way that we changed our thoughts on AIDS was the same way that you're seeing here. In the beginning, it was known as GRID, the gay-related immunodeficiency disease. It was also the 4-H disease, targeted heroin users, hemophiliacs, Haitians, and homosexuals. This is all before it actually had the name of HIV and AIDS. The National Cancer Institute referred to a year after the CDC came up with those two names. The National Cancer Institute director just referred to Kaposi sarcoma, opportunistic infections acquired immunodeficiency syndrome, and that's what they called it, till they came up with HIV and AIDS a couple of years later. So this is the way that the change happens. In school, you learn about hand washing. When I was in school, we learned stop, drop, and roll, or go get under our desk because you thought there was going to be a nuclear blast. And so we have different levels. Your generation is taught about AIDS and HIV in school, and safe sex. The word sex in my generation was something you kind of really didn't talk about. Although I lived in a house where that was, because my mother was so involved in the AIDS crisis that we knew that. So Shenandoah University, by far, is way ahead of the game in not just their knowledge, but the fact that they're willing to hold any kind of programs like this, to talk about it, and then hopefully the next generation that comes through will learn from our generation, and they'll learn about not just Ebola, but in the middle of this Ebola outbreak in West Africa, there was a totally separate Ebola issue in Congo that quickly burned itself out, and we had cases of Marburg hemorrhagic fever in Uganda. We've got other diseases that are everywhere, and now we're in a state of media knowledge, and the media are sharing so much knowledge. It's not always the best, but as we work through what's right and what is fact, and we can actually address that in the schools so future generations can actually deal with it better.
It's back to what we said in the 1990s. We need an effective global surveillance system to be able to predict when these next epidemics and pandemics are going to occur. I'd like to ask the panel members if they have any few sort of final words to say. I think we probably should wrap up fairly soon. I know you've stayed quite a long time, but Kathy and Gilda in particular, and Ron.
Well, I just wanted to follow up from that question and also what Maggie was saying. Did you notice how inflated everything got as the media got involved? And people really were getting into a state of panic. And so, organizations like Shenandoah or the school systems or whoever it is were trying to make the decision, okay, do we address this publicly or do we just let people watch the news, and feel like they're safe. And what we decided to do is to say, hey, Shenandoah community, we know that this is a problem. Here's what we're doing. And I did the same thing in the School of Nursing. I sent a note out to the faculty and students and said, listen, you actually need to worry about getting the flu more than you need to worry about this. And so here's the things that you can do, because I think that's the other piece of it. People get upset and nervous about it, and there's nothing they feel they can do. And so here are some things you can do. You can go get your flu shot, as Dr. Vine said earlier. You can wash your hands a lot. Not necessarily with bleach, but just wash your hands and think about the next time you blow your nose or you shake hands with somebody or whatever it is. And those are things we should always be thinking about, especially every winter when we're in flu season. And so I think the best thing is correcting misinformation and then being proactive and providing really good information that now you can take it out there and share it with people that you know, and then it grows from there.
That's it. Well, that's tough to follow up. The one thought that came to my mind is when you said about being different generations. And, in the course of our nursing career, some of us have been up here in nursing for a number of years. And I remember when I first started, we washed our hands at the beginning of our shift. And there wasn't a lot more that was said about that. We started IVs with no gloves. Even 5 to 7 years ago, when I was clinically practicing, you could wash your hands with soap and water, but the alcohol-based rub or chlorhexidine-based rub wasn't installed at every patient's door yet. And when it was initially, people didn't use it. Then we came out with the Speak Up campaign from the Joint Commission, and those flyers were handed to patients, and patients started saying to their physician and their nurse, you didn't wash your hands when you came in my room. Now, it is almost not found that a healthcare provider will walk into a room and not wash their hands or use an alcohol-based cleaner. It's there because not only do we have the technology, we know that this works, alcohol-based as well as soap and water for most things, but we have installed it so that we can use it. And so we have the tools now to combat something like Ebola that even 5 years ago, our clinical practice was not capable of doing. And I think that's one of the things, and the same is true for HIV with treatments, the pharmaceuticals that are available now. Just a few years ago, we didn't have that opportunity, and I think that's one of the reasons that it goes out of the sensational media so quickly, is because we are able to come up with good strategy, and we have the technology to cope.
The last thing is, you have to understand, this is our third trial with outbreaks of different things, from SARS to H1N1, the bird flu, and now this. What the coordination that we do on campus, the collaboration we do with off-campus services, the hospital, the health department. I am in regular contact with the health department every year. Not every month, thank goodness, but I am constantly in contact with his staff. They're very helpful. They work with me very well to help train our staff and make our policies. So this is something that is just second nature to us by working with them. And this is what it's proven, and now bringing the School of Nursing in, Dean of Health Professions in. Now we're collaborating internally even more as well as externally.
Any further comments? In which case, it just remains for me to thank you so much, audience, for coming tonight, and to thank the panel members for a really, really informative session.